Alright, let's get started with a look at abnormal behavior, which is also known as disorders. First, we'll start with the idea that there are many common misconceptions about abnormal behavior. We'll be talking about those. But before we get into the details, I want to give the caveat they give to any psychology student, whether it's high school, college, or wherever, and that is, as we get into some of these disorders and discuss them, some of the characteristics that you will hear may sound a little bit like something that perhaps you've experienced on a temporary basis, or maybe even more so. But the big caveat is, do not think that you are mentally ill, because it's not true. If you're able to function, and that's really one of the big bases of mental illness, is the fact that the people who have it cannot, then you have some difficulty. So as we look at these definitions, make sure that you understand that you are fine, there are no problems, and what we're talking about are people that have abnormalities. Alright, moving forward, let's take a look. The issues we'll look at are the medical model of abnormal behavior, criteria, stereotypes, classifications, and the prevalence of such things. Let's start with the medical model. This is the way psychology approaches abnormal behavior or disorders, and it treats it as a disease. Thus, the person is seen as more of a victim rather than the cause of the disorder. Now, this view of mental illness started in the 1700s and 1800s, still has a strong influence today. Prior to that, mental illness had been seen as relating to the supernatural or the fault of the person themselves. But of course, today the idea is that it's very much a disease, as you would describe any kind of other physical disease that someone might have, some sort of illness or sickness. So the analogy that it is like that is still widely supported. And psychology uses the medical model. In other words, we use the terminology and the approach that you'd find in physiology or in medicine, including terms like diagnosis, which is the distinguishing of one disease from another, etiology, which is the apparent causation and development of an illness, and then finally prognosis, which is a forecast of a probable course. Alright, so what are the criteria that are used to define abnormal behavior? First, there's deviance, and that means that the behavior of the individual deviates from what society deems to be acceptable. Second, maladaptive behavior. That means everyday adaptive behavior is impaired. This is often found with people that have drug abuse or alcoholism. Their everyday behavior is impaired. And finally, personal distress. An individual's report of personal distress to a therapist or to others. You'll often see this in depression or anxiety disorders. Often two of these three are seen, but only one is needed for a diagnosis of abnormal behavior. It's obvious, however, that much of diagnoses is based on the value judgments of the medical professional, and so the truth is that the views of what is mental illness and what isn't have changed over time. For instance, as late as 1973, in the Diagnostic and Statistical Manual of Psychology, homosexuality was actually classified as a disease. So the idea is that society, in essence, deems what is considered to be normal and considered to be abnormal. Overall, on occasion, everyone acts in somewhat deviant ways or feels some distress. Thus, normality and abnormality exist on a continuum. It's a matter of degree, not an either-or proposition. One major example of a stereotype about psychological disorders that is inaccurate is the stereotype that psychological disorders are incurable. The truth is, the vast majority of people diagnosed with disorders eventually improve and will lead normal lives. Let's take a look at the classification of disorders. Prior to 1952, the criteria were vague and informal in the field of psychology, but in 1952, the American Psychological Association published its first version of what becomes known as the Diagnostic and Statistical Manual. So DSM-1 came out in 52. They revised it for DSM-2 in 1968, DSM-3 in 1980, DSM-4 in 1994. They revised it in 2000, and the newest edition, which is DSM-5, came out in 2014. Today there are 3 times as many disorders described in the DSM as there were back in DSM-1. So what about the prevalence of psychological disorders, or how common are they? Prevalence is the percentage of a population that exhibits a disorder during a particular time period. Estimates vary widely as to the overall prevalence of disorders. Currently, obviously, the definition of specific disorders has varied with changes in the DSM over the years, but current research sees 1/4 of all adults over age 18 suffering from one disorder in any given year. So that's actually a lot more than most people might think. Now, some of these are minor. Not all of them are major disorders, but 1/5 of all adults over age 18 have something going on at least once a year. And the most common disorders are substance abuse disorders, anxiety disorders, and mood disorders. Okay, now on to the important stuff, the actual classifications. And we'll start first with anxiety disorders. Anxiety disorders, although everyone feels anxiety occasionally, an anxiety disorder is defined as a disorder marked by excessive feelings of anxiety and or apprehension. Again, the key here is the person is incapable of functioning in society. We'll take a look at the 5 types of anxiety disorders. First, there's something called generalized anxiety disorder, and as we go through the categories of different disorders, you'll find that there are oftentimes sort of a catch-all category that's there for things that they know are part of that disorder, but they just can't pinpoint exactly what it is. That's this particular category. When people have this, it's marked by a chronic high level of anxiety, not tied to any specific threat, so they're just anxious without anything in particular that they're focusing on. They seem to worry constantly over little things, over big things. They are often brooding. This is often seen with physical symptoms like dizziness, etc. It's called generalized anxiety disorder. The second one, phobic disorder. This is a persistent and irrational fear of an object or situation that offers no real danger. There are sometimes physical symptoms like trembling, but the problem is that people are unable to calm themselves. So this would include a lot of the phobias that you're familiar with. Acrophobia, the fear of heights, hydrophobia, which is the fear of water, and brontophobia, which might be prominent in the Dallas-Fort Worth area. It's the fear of storms, arachnophobia, claustrophobia, etc. The key is the person is unable to calm themselves. Number 3, panic disorders. 2/3 of the people that suffer panic disorders are female. These are reoccurring attacks of overwhelming anxiety that usually occur suddenly and without warning. This can lead to agoraphobia, which is a fear of public places or open spaces, because the person has the fear that the attack may occur when they are in a group of people and then they'll be embarrassed. And so this often causes people to just stay home when they have agoraphobia. They do not want to go outside. The 4th, probably one you've heard of before, and that would be OCD, or obsessive compulsive disorder. Now you need to remember what these terms mean. Obsession is a thought and compulsion is an action. So the compulsions are often ritualized acts. So what you have here is people will have consistent thoughts about something. In fact, they get way too focused on it. They become obsessed, which means it keeps them from being able to function normally in society. And usually the two are paired together, this is paired with a whole bunch of compulsive actions that must take place. They'll often be very ritualized. They have to go through a full ritual before they can do anything, and if anything is out of place, they're unable to move forward. So it becomes somewhat paralyzing. And the 5th one is acute stress disorder, or ASD. The symptoms of ASD often occur immediately after a traumatic event and include anxiety, dissociative symptoms. We'll be talking about those in a minute. These are symptoms such as emotional numbness, a lack of responsiveness, not being aware of surroundings, even having dissociative amnesia. They'll often have reoccurring nightmares, sleep disturbances, problems in concentration, and moments in which people seem to relive the event in dreams and flashbacks for as long as 1 month following the event. When the symptoms associated with ASD last for more than 1 month, the disorder is then called post-traumatic stress disorder, and we've talked quite a bit about this in class and the physical causes of that particular disorder. So let's take a look at some of the factors relating to anxiety disorders, or the things that might cause it. The biological view is that there is a genetic component to it. In fact, there's a moderate genetic predisposition to anxiety disorders. And looking at what neuroscience says, the neurotransmitter GABA or GABA is related to some types of anxiety disorders. OCD seems to have a strong connection to serotonin. Like many disorders, conditioning can set up situations where those predispositions are actually triggered. There we go, behavioral conditioning. And cognitive theorists argue that incorrect patterns of thought can cause anxiety disorders. And interestingly, the treatment for these tend to be first some sort of a drug therapy, and then a lot of cognitive therapy to teach the person to look at situations a little bit differently. You can also see that other theorists see high stress as a contributing factor. Alright, now let's take a look at somatoform disorders, and this is a term that's often confused with the term psychosomatic disorder, and it has been widely misused. Psychosomatic disorders involve genuine physical disorders caused in part by psychological issues, especially issues related to stress. So examples would include ulcers, asthma, and high blood pressure. There are true physical problems here. The ulcer, the hole in the stomach, we talked about the executive monkeys. Asthma, there is obviously a clogged breathing tubes that occur, but psychological problems can influence that. And of course, high blood pressure, the more stress you put yourself under, the higher your blood pressure will be. All are physical, but influenced by psychological factors. Somatoform disorders are different. They are physical ailments that cannot be explained by organic conditions and are largely due to psychological factors. The symptoms are more imagined than they are real. So let's take a look at three types. The first one is somatization disorder. These are people who cling to ill health. They often have a history of diverse physical complaints that appear to be psychological in origin. The distinguishing feature is the diversity of the victim's complaints. Generally, these people cling to ill health and always seem to be ill. Number two, conversion disorder. Now, this is a very interesting one. It's a loss of physical function without any organic cause, usually a single physical symptom. Example of this would be losing your vision, losing your hearing, some form of paralysis, becoming mute. Probably the best example of this one, and the one that probably is one of the more fascinating things that we're looking at here in disorders, is something called glove anesthesia. And this is where somebody will actually lose the feeling in a limb. In this case, it's actually the hand itself. And they will feel absolutely nothing there, no pain, no sensation, but further up the arm they'll be fine. So it's almost as if they have put a glove over their hand in order to anesthetize it. There are times when what sense and what sensation is lost is actually related to some sort of an event or activity. If you see something that you cannot deal with, perhaps your vision would go out, etc. But the glove anesthesia example is a pretty amazing one. The next group is people who have hypochondriasis, or the so-called hypochondriac. Now, these are people who have excessive preoccupation with health concerns and incessant worry over physical illnesses. They often overinterpret every physical sign of an illness. The factors for somatoform disorders: personality type, more often. Those who are self-centered, suggestible, excitable, overly dramatic, and insecure will tend to get this one. The person who looks at this often has faulty standards of what good health is, and so that's the cognitive view. They have incorrect patterns of expectation of their good health, and so they overemphasize their internal workings. We all have little quirks that occur, and the people that have these ailments tend to focus on them a lot. And the third one's an interesting one. It's a conditioning one, and it's called the sick rule. Because when people are sick, others actually pay attention to them and give them a lot of help and empathy. There are people who just will take that to the extreme and become sick, and in this case, it would be people who actually feel the actual ailment, even though it's not really there, that's pushed by the sick rule itself. Alright, and the next thing we'll move to will be the dissociative disorders, and we'll pick up with a very brief segment for that and then head into a pre-recorded segment as the next one.